today we are gathered here to talk about Lemborexant, which is a novel sleep-inducing medicine, and it is available in India by the brand name of Davigo in 5 milligram and 10 milligram tablets. The Lemborexant is a dual orexin receptor antagonist, in short, DORA. So for all those people who have watched the cartoons of Dora, you know that Dora was a very smart girl. Therefore, Lemborexant also is a very smart medicine, and it has decided to solve or partly solve the issue of insomnia by a new mechanism. So how is Lemborexant thought to work? So this is working on the orexin receptor system of the brain. So why is it novel? Because till now, we have all used the GABA receptor to initiate sleep by inhibiting the brain mechanisms. And we use the benzodiazepines and the Z drugs, which both work on GABA receptor, causing allosteric modulation, resulting in an influx of ions, causing hyperpolarization, and therefore the brain settles down, calms down. So since there were limitations in the use of benzodiazepines and Z drugs, therefore scientists were trying to find a new way of enhancing sleep induction and sleep facilitation. The orexin receptor system in the brain, which is what you can see here. So this has two receptors, orexin 1 and orexin 2. Now Lemborexant works on both, but it binds competitively and therefore it antagonizes its action. Now what it results in is that the orexin system causes wakefulness in the brain. And therefore Lemborexant, by binding and antagonizing the orexin receptor system, inhibits the wakefulness system. Thus, our wakefulness drive goes down and therefore sleep comes by itself. Now, that seems very perfect because we expect that it will not cause dependence. And further, Lemborexant does not have any binding at all with other brain receptors such as serotonin, noradrenaline, acetylcholine, dopamine, all those which we psychiatrists are usually very prone to use. Therefore, it is expected that it will not cause any side effects. This is the mechanism by which the orexin system is inhibited by Lemborexant so that the wakefulness center becomes weaker and the sleep center becomes stronger. Now, orexin receptors are very few in the brain. Therefore, by definition, we expect that Lemborexant will have precision targeting and therefore less side effects. For example, it does not cause any wakefulness in between, does not cause any muscular or postural instability, and does not impact on cognition. Now, what is the evidence behind Lemborexant? The evidence is of two pivotal phase 3 trials termed as Sunrise 1 and Sunrise 2. Sunrise 1 was a 1-month trial and Sunrise 2 was a 6-month randomized control trial, followed by a 6-month extension period of another 6 months trial. What did we find in these trials? That sleep onset latency, that is the time which is taken by the patient to fall asleep once they lie down on bed, has improved and it has reduced from 19 to 32 minutes by 19 to 32 minutes. Secondly, Lemborexant also reduces the wakefulness after sleep onset. So let us say you have gone to sleep, you have achieved sleep, yet after 3 or 4 hours, your sleep is breaking and now you are awake and are unable to go back to sleep. Lemborexant reduces this time by 44 to 51 minutes based on these two trials. And therefore, overall, the sleep efficiency also increases. Now, this sleep maintenance was measured both by polysomnography, that is in the sleep labs, as well as by patient diaries. So subjective as well as objective component. And as you can see here, this was a comparison between Lemborexant 5, Lemborexant 10, placebo and zolpidem 6.25 ER. And the result was that wakefulness after sleep onset. So in the second half of sleep, when a patient would wake up, that time was reduced by Lemborexant by almost 30 minutes. On the other hand, those on placebo had a reduction of only 11 minutes, and those on zolpidem only a reduction of 20 minutes. This was statistically significant with t less than 0.05. Lemborexant does not have any drug tolerance. So in the Sunrise 2 trial, which as I said continued for over 1 year, 12 months, it showed that its effect, its effectiveness, its efficacy continued without any waning effect as we see with benzodiazepines. And that tolerance leads to dependence as we have to increase the medicine and we cannot stop the medicine. But Lemborexant does not have this effect. It continued to cause the same beneficial effect to people over a period of 12 months. Thus, there was no signs of tolerance. Now, if we look at the summary of adverse reactions, now as we might have thought, it does cause somnolence or fatigue. In people more than 65 years of age, there was a 5% increase on 5 milligram and a 10% increase on 10 milligram. Some patients complained of headache and nightmares, but as you can see from the slide, comparisons between placebo and Lemborexant 5 milligram are very fair. Almost non-significant differences between placebo and Lemborexant 5 milligram. But yes, 10 milligram does cause some somnolence, drowsiness, daytime fatigue, and sluggishness. Therefore, the recommendation is that in elderly people, we start with 5 milligrams and not with 10 milligrams. So this is the chart as to how the trial was conducted. The Sunrise 2 over a period of 12 months, where initially 971 patients were randomized into 3 groups for the first 6 months. After 6 months, those who were randomized to placebo actually were re-randomized to receiving treatment. Overall, about 90% patients completed the last 6 months and they felt that they were benefiting. There were some people who discontinued, 9.2% at 5 milligrams and 8.4% in 10 milligrams group. And most were lost because of loss to follow-up, subject choice, or inadequate therapeutic effect. Now, as psychiatrists, we all strive to give good sleep to our patients who have depression and anxiety, but with comorbid insomnia. Now, many a times our SSRIs, which function very well for depression and anxiety, can sometimes cause sleep disturbances as well, especially the activating SSRIs. Therefore, there was a subgroup analysis in the Sunrise 2 trials of whether depressive patients were also benefiting by Lemborexant. Please note, this depressive group had mild depression, so the BDI scores was less than 19. And what was found was that the Lemborexant group also had a beneficial effect compared to zolpidem and placebo. Therefore, Lemborexant is not inferior in any way to zolpidem. This is a subgroup analysis of patients who had anxiety, again mild anxiety with a Beck anxiety inventory score less than 15. And here again we found that Lemborexant 5 and 10 were equally affected or better than zolpidem ER at 6 months. Further subgroup analysis was done in a group of Asian adults. Now, unfortunately, this Asian adults does not include any Indian group. It had Japanese, Chinese, and Korean groups. But what it does tell us that in Asian groups as well, within the age of 55 to over 65, at month 12, the median change in sleep onset latency was maintained with 25 to 27 minutes of beneficial effects. So you are sleeping within 25 minutes of taking Lemborexant. Your sleep efficiency during the 12 months of period that you took Lemborexant also improved by 14.5 and 12.8 at 6 months and 16 and 15 at 12 months respectively. Wake after sleep onset, as I said, also reduced so that you are not waking up as often at 50 and 27 minutes respectively. Total sleep time increased by more than an hour from baseline on Lemborexant 5 and 66 minutes on Lemborexant 10. Surprisingly, when you look at the adverse reactions in the 12-month study period, we find that nasopharyngitis was a very common side effect. I assume that that cannot be caused by the active drug moiety because there is no such mechanism in which it goes to the nasal mucosa. I suspect this might have been a coincidence. Somnolence, headache, fatigue, sluggishness, yes, they were present in 12-month period among the treatment initiators, among Asian subgroups, and these percentages range from 10 to 15%. So overall, what we found in that 12-month study was that there was no rebound insomnia following treatment discontinuation. You will note that after 12 months, since the study ended, the researchers still followed up patients for 2 weeks without Lemborexant. And what they found was there wasn't any rebound insomnia, and for most patients, the sleep effectiveness was pursuant. Similarly, there was no active withdrawal effects following Lemborexant discontinuation. Now, as doctors, we are always aware that our medicines should not cause any harm to our patients, and safety assessments were undertaken in phase 1 and phase 2 trials for Lemborexant. In phase 3 trials, what we have found is that despite taking Lemborexant 5 or 10, patients had postural stability which was much better than on those with zolpidem. So in the morning when you wake up, your body will sway on zolpidem, but in Lemborexant this does not happen. Even in the middle of the night, they woke up patients to check whether they were able to be stable while walking to the loo. And they found that patients on Lemborexant 5 and 10 did not have as much body sway as patients on zolpidem had. We know that Z drugs, especially zolpidem and zopiclol, both have a risk of falling at night when a patient wakes up to go to the toilet. Lemborexant has a lesser risk than that. Similarly, in the morning, after you've taken a sleeping pill, your cognitive performance, especially on driving, can be impaired. But what safety assessments have shown is that with Lemborexant, it did not cause significant impairment compared to placebo. So almost as well as placebo, you can wake up feeling alert and able to focus on driving. There is no drug abuse potential as suggested by 3 non-clinical studies. Even though somnolence is an adverse event, it does not cause as rapidly as it does with benzodiazepines, and therefore the chances of having a high is much less. Zopiclone, as we know, does cause a feeling of high in many patients, and therefore it has been used for that abuse effect, but Lemborexant has somehow not meant that. Other safety studies were about respiratory safety, and even patients with mild obstructive sleep apnea were given Lemborexant safely. Poor administration of alcohol, I mean, it has been shown to not be additive, but I suspect that it would cause additive effects with Lemborexant. Drug-drug interactions are definitely there, which we'll talk about later on. Especially hepatic impairment, we have to reduce the dose of Lemborexant. Now, this slide shows that the number needed to treat, versus placebo is as robust as 3. What that means is that if you give 3 people Lemborexant, then and 3 people placebo, then you'll be helping at least one patient sleep better. At the same time, the number needed to halve, which means that if you give 10 people Lemborexant and 10 people placebo, Lemborexant may not cause any harm to those 10 people. Somnolence, yes, it is the most common adverse effect, with the number needed to harm estimates of 28 in Lemborexant 5 and 10 and 15, in Lemborexant 10 mg respectively. So overall, this study suggests that the NNT values and the NNH values are significantly in favor of Lemborexant versus placebo, and that we should not be very afraid or very cautious when we start Lemborexant to patients who need medicines. Transitioning from benzodiazepine to Lemborexant, it has been suggested that we should not suddenly stop benzodiazepine because of a withdrawal reaction and a rebound insomnia. Therefore, many times what I have done is I've added Lemborexant And after a week, then reduce the benzodiazepine and continue to reduce it every week by some amount so that ultimately our patient can be stabilized on lemborexant. Pharmacokinetics suggests that it reaches its peak concentration in 1 to 3 hours, but usually its maximal effect, the sleep-inducing effect, arises in about half an hour. So what I suggest to patients is take it when you're ready to go to sleep, then lie down and wait for it to have an effect. And usually within half hour, you will be able to sleep. And even though the half-life of lemborexant is 17 and 19 hours at these doses, it does not persist in its impact on sleep or awareness. CYP3 inhibitors like fluconazole and itraconazole should be used very, very cautiously with lemborexant, as it will lead to an increase in the impact of lemborexant. On the other hand, use of bupropion with lemborexant leads to a reduction in the effect of bupropion. That is because bupropion is a very weak inducer, but lemborexant causes metabolism to become faster. So the overall dosage that has been suggested by the innovator is 5 milligrams to be started at night, to be given at bedtime, and wherein at least 7 hours of sleeping time is planned. There is no need for dose adjustment based on age, sex, and BMI, even though cautiously I would say please use 5 milligram in those who are above the age of 65 years. No dosage adjustments are needed in mild or moderate renal impairment, but in hepatic impairment, especially mild to severe, we do need a reduction in the lemborexant dosage. So clinical summary based on these two large randomized trials is that lemborexant is a good medicine to be taken once at night. Compared to benzodiazepines and the Z drugs, lemborexant works on a very different receptor, not on GABA modulator. It has beneficial impact on REM sleep. It does not have rebound insomnia. So my summary is lemborexant has a good place in our armamentarium for managing insomnia, even if it is comorbid with depression and anxiety. It's a non-benzo, non-Z drug for sleep. It inhibits wakefulness. Sleep onset latency improves, waking after sleep is reduced, morning drowsiness is very less, and no major side effects apart from somnolence. No evidence of rebound insomnia, less dependence. The only limitation that I could think of is the high cost in India. At the moment, it is in a patent, therefore the prices are 44 and 64 approximately for 5 and 10 milligrams medicine. Now we come to the experience sharing. I can see that Rajiv is here, and I'm sure some other psychiatrists have joined. Dr. Shashi Bhushan is here, Dr. Kushal Jain, Dr. Gunjan. So I'm just giving you my experience, right? My experience with lemborexant has been fairly good. So for example, one anecdotal evidence I'm providing, 57-year-old female, which complained of problems in sleeping for 6 months, off and on. She was slightly anxious, but there were no other reasons as such which would trigger her sleep delay. She complained of not being able to sleep on some days, and on some days on having good sleep. But the more important that she was worried about was daytime fatigue. So we started Dayvigo at 5 milligrams, and what I found was that her sleep onset reduced to 30 minutes. And she was fairly happy with that because it was sustained. So on every day that she took lemborexant, she was able to sleep within 30 minutes, and her sustained sleep was also benefited, so that her daytime fatigue was reduced. That meant that her quality of life improved and her mood lifted as well. She was not on any SSRI. So I'm sure some of you can also share such an experience. Second case that I'm sharing is a 34-year-old male used to take alcohol, decided to stop alcohol 4 weeks back. He did not receive any treatment for alcohol withdrawal as he chose to do it himself. But even after 4 weeks, he said that although he was able to control alcohol and not take it, but his sleep was disturbed, and that caused a problem. He felt that he was unable to focus on his work in the daytime, and that he would toss and turn at night. We started him on Davigo 5, then increased to 10. And what I noticed was that at 10 milligram, he was feeling much better. And then we were able to reduce his benzodiazepine dose, which he had been illicitly procuring from the market. So from about 2 milligrams of clonazepam that he was initially taking, we brought him down to zero point 0.5. After that, he was lost to follow-up, but I assume that he is doing well. Case 3 is a unique case. He had a sleep behavior disorder where he would wake up in the middle of the night and suddenly behave very, very abnormally. He used to keep a camera focused on himself and record the camera findings, and he showed me that how he would shout and scream in the middle of the night. He had tried clonazepam, which is a drug of choice for a behavioral disorder, but that didn't help him. We tried him on mood stabilizers, tried him on anxiolytics, tried him on venlafaxine, didn't work. We also tried him on Davigo. Now, if you have seen, Davigo does not impact much on REM sleep, although it can enhance some REM sleep. But in this patient, we did not see any change in his sleep behavior disorder. And despite using it for about 3-4 weeks, since there was no change, the patient dropped out of follow-up. Last case, 45-year-old female. She lives alone. Her husband works in a different state. Her children are college going, they live in the hostels, 2 children. So she lives alone, basically. And her main problem was that because of loneliness, no structure to the day, she had a lot of anxiety about whether she'll be able to sleep or not. But her anxiety was also associated with not taking any medicines because she was anxious about getting dependent, about falling down, about losing her memory, as she had read all of those on in the internet. So initially I tried CBT insomnia. That worked partly, but her anxiety did not reduce because she was still having difficulty in initiating sleep. So I convinced her by prescribing Davigo 5, and she read up on the internet that it wasn't causing rebound insomnia, did not cause dependence, did not cause cognitive dysfunction. So she was reassured. She started taking Davigo 5, and initially for the first week she did not have much benefit. But after the first week, from the second week onward, she said that yes, her sleep initiation had become better. And after about 4 to 5 weeks, she reported that she feels better overall, not only in terms of sleep anxiety, but also in terms of being less anxious in the daytime, even though she still lived alone. So those are my 4 case reports. Thank you everybody for sparing your time to listen to me. If you have any feedback about the presentation, please do send it to me on my email or my phone number. Thank you.